focus more on pain and symptom relief when your medicines were not going to work, and it's okay to stop things that weren't working or to not do things that were never going to work, like CPR, that you don't shorten anybody's life. And in fact, because some of those things are dangerous, people might actually live longer. But it's very counter to traditional medicine, where we keep trying to fix. But care should go beyond death. And as part of hospice, that's actually included in a formalized program called bereavement, where the family is still there, their loved ones are still there, grieving the loss of their loved one, and who's there to support them in some way. So the care shouldn't stop at death. The care should go beyond death, and that's the bereavement. Which one sounds like a better way to approach the care of patients? Most people would say the bottom one sounds like what it makes sense. It just makes sense. So to do this, you need the team approach. It's not just about me. We need a team. I'm not trained to deal with all the aspects of a patient's care needs, whether it be the social suffering a person's going through, understanding their benefits, the finances, what resources are available in the community. As a physician, all of that is changing so much, I don't necessarily keep on top of it all. So this is where our social workers are dramatically helpful. Spiritual support, dealing with a crisis of spirituality or distress that dealing with death can bring on a patient and their family, is not necessarily my strong part. And we work with chaplains to deal with this, to help support the patient and their family with that spiritual support and those questions that they have about death and dying and what it means and the meaning of life, that as the doctor, I'm not trained to deal with. I'm trained to identify and to ask for help and to work as a team and to communicate with the expert in that to help them understand more about where the patient is and what they just heard so they can better help tend to their needs. That's how this teamwork helps, the communication within the different specialists or the different members of the care team. The primary care physician, a lot of the times patients have the idea that I take over everything. I try not to do that. I try to be a member of the team. I want to help the physician who's been caring for this person the longest and who knows the patient the best, whether that be their primary care doctor or their oncologist or their nephrologist or their cardiologist. This primary care role is different for every patient, but I think that physician always has something to offer that patient, but I can help come and address those needs and add to the care, not necessarily take it over. And everybody usually has about 5 or 6 doctors when they're dealing with a lot of illnesses, and who's coordinating with all of them? In the hospital, it gets very confusing these days. And so our team just tries to make sure everybody understands what the patient wants and what decisions are being made so that they can help be on the same page and offer the treatments that are consistent with this patient's wishes. So how do you identify? This is more of a slide that I talk to a lot of physicians and nurses and healthcare professionals about, but I think it's great for everybody to see. It's not an absolute numbers, but it helps give an idea. For most doctors, what the question I usually tell them is, they'll ask me, well, I don't ever know when a person's got 6 months or less to live. I can't say that, and I can't sign papers that say that. What I would say is, well, that's not really what they're asking. What they're really asking more is, if in the next 6 months I told you this patient had died, would you be surprised? And if the doctor says, no, I wouldn't be surprised, why aren't you talking about palliative care? If you're not going to be surprised, the patient and their family might be terribly surprised. And if you didn't tell them that you're not surprised by it, all too often I'm seeing that everybody else is totally shocked that this is happening. But the doctor kind of knew. So that's the better question to ask. And what I'll say for palliative care is 2 years. Would you be surprised if in the next 2 years this patient died? And if the answer is no, you're not going to be surprised, probably a good referral for palliative care. Even with treatment, or especially with treatment, I should say. So if we have a lot of cancers that are very treatable, but they might add a year or a year and a half to life, but still we should be talking about palliative care. Palliative care has a whole lot to offer for those patients and might actually, according to the studies, add time to their life, good quality time to their life. And maybe avoid a lot of other burdensome things that they would not have wanted if they only knew. And they only had a chance to plan ahead. So for cancer, most types of cancer that are metastatic or have spread far away from where they started or are deemed inoperable, we need to be talking about palliative care. When it comes to cancer, it all depends on function. Really does. Just because a cancer is spread doesn't mean a person has less than 6 months to live. There's patients with cancer at stage 4 who are alive 5 years from the time they're diagnosed. But what's really tied to the diagnosis of cancer is functional status. How functional is the person? Can they take care of themselves? Are they able to walk? Or are they mostly in bed or mostly in a chair? Because that makes a tremendous difference to what options are available and actually makes a tremendous difference to prognosis and life expectancy. Very well documented. There's actually calculators now that doctors can punch in a computer, say what type of cancer, the patient's functional status, the cell type, and a lot of information, and the computer will actually tell you how long a person probably has to live. That information is available. But we don't use it very often. I would say that computer program really doesn't matter. What matters most is talking with the patient, because there's no thing that's going to tell you the future. But it's nice to have an idea so you can plan for what happens if. I usually say, let's plan for the best, hope for the best, but we need to plan for the worst too. We can keep hoping for the best. I'm not here to destroy hope. I'm here to give you hope, to focus on what's possible, what's achievable, and making sure that we're doing what you want us to be doing. That sounds like a lot of hope to me. Or you can say realistic hope. Heart disease, my cardiology colleagues are extremely good at fixing hearts. A lot of the major advances we made in medicine in the past 20 years have all been about fixing hearts. Heart surgery, opening up blood vessels, using stents, advanced techniques like heart transplant, left ventricular assist devices, which are basically tiny motors you can put in somebody's heart that keeps the blood flowing even if you don't have a pulse. Vice President Cheney had such bad heart disease. He had multiple heart attacks since he was 30. His heart got so weak that it was giving out, and he had a device implanted that even though he had no pulse, he had blood flow. And it let him live long enough to get a heart transplant. And then he got a heart transplant, and now he's pretty functional. I don't want to get into the politics of it. That becomes debatable, right? But a patient who has a very low ejection fraction, which is how much of the heart squeezes every time it beats, who are having arrhythmias or have had a cardiac arrest or having strokes caused by their heart, coming into the emergency room very often because they're short of breath, and this is as good as it gets. The doctor said, we've given you every medicine, you're taking all the medicines, you're following all our directions, but still you come back to the hospital because you can't breathe. We need to deal with it. There is some more treatment we can be doing, but we need to talk about goals. We need to know what's most important to the patient. It might be a heart transplant. It might be not. It might be that they're just not a candidate for one. So what else can we do? End-stage pulmonary disease or chronic obstructive pulmonary disease, emphysema, where a person is short of breath even at rest, even on oxygen, even on all their medicines, even when they're doing everything properly, still short of breath. So short of breath that it's impacted their quality of life, that they can't do things that they used to do because the shortness of breath just is incapacitating. Low oxygen saturations, even if we put them on oxygen. Unintentional weight loss, it tends to be not a good sign. So when these things are happening, these things happen way before death happens, usually months or years. And it's a sign that we need to talk about things. Dementia is going to become much, much more prevalent. It's already tremendously prevalent. As we fix people's hearts and fix their cancer and fix strokes and do a lot of other things, still there's certain processes that we don't have treatments for or cures for. The best Alzheimer's medicines or dementia medicines don't stop the disease. They slow it down. They make the decline more gradual. And they try to keep the patient as functional as possible and adding potentially years of good quality of life. Those are palliative medicines. They treat symptoms. They improve quality of life, but they're not curative. They're palliative. But eventually, if the disease does run its natural course, and a person loses the ability to speak and walk, and then something happens like a hospitalization for pneumonia, that's the disease entering its final phases. And certainly before that happens, it's appropriate to plan for it, hopefully when the patient can make their own decisions. Because just because a person has dementia doesn't mean they can't say what they want. There's certain decisions they certainly can make. But if we wait long enough and the patient can't talk anymore, and there's a crisis and nobody talked about what the patient would want, this is where we start entering a whole lot of burdensome interventions like feeding tubes, which the evidence would say, all the scientific studies done in the past 20 years, for patients who have advanced dementia, feeding tubes do not work. They do not work. They do not prevent pneumonia. They do not prolong life. And that's in a scientific study. In reality, you look around the country and every city treats it differently. In the Rio Grande Valley, we have a tremendously high use of feeding tubes, even though the science would say they don't work. What I would say is it depends on the patient. It depends on the patient. Locally, it's become ingrained in our medical culture. If you can't eat, or we do a swallowing test, and if you have advanced dementia, suddenly it means feeding tube, the science would say no. You need to talk about it. It depends on what's important for the patient, but you can't promise that it's going to prevent pneumonia, and you can't promise it's going to make you live longer. But not many doctors are trained to talk about it like this. Some facilities have gotten to the point where if any patient is ordered to have a feeding tube, that it's an automatic palliative care consult before it's ever done. So you're not allowed to get a feeding tube until you talk to a doctor like me, because there's a lot of decisions, there's a lot of consequences to it, good and bad. And we have to know them both. We need full informed consent. Liver disease in a patient who can't get a transplant, renal disease in a patient who doesn't want dialysis, or has been on dialysis and doesn't want it anymore, or is on dialysis, period. I would say, if you're on dialysis, it's probably a good idea to have a palliative care consult. Studies would say that dialysis patients have a frequency of pain equal to that of stage 4 cancer. But nobody's really addressing all of it. Medicare makes it very complicated for a dialysis patient. Very complicated, because for a dialysis patient, they can't be on hospice typically, unless they choose to stop dialysis, which is a very big deal. But certainly, we can bring palliative care, because that's always appropriate, into their treatment and still address a lot of the things that need to address. Pain and suffering, symptom control, planning for the future, goals of care, all of this is appropriate. I guess the theme is it's never too early for palliative care. And I've said goals of care, goals of care. What does this mean? It's really a way of giving the patient the information they need to tell their physicians what's most important to them, how they want to be treated. A lot of the times, doctors always assume that the patient wants cure, but they never asked. They never asked. They just assumed it. If a person comes to me, it must mean that they want me to fix them. Well, what's the consequences of that? What's most important to that patient? What will be the side effects of your treatment? That matters. That helps the patient truly understand what's going to happen so they can plan. And they can tell you now what's most important for them. To do this, you need to have time. These kind of conversations don't happen in 5 minutes. They just don't. And I know we see the way the reimbursement model drives physicians to maybe see 5 patients an hour, 10 patients an hour sometimes. And in the Valley, where we don't have that many doctors compared to everywhere else in this country, but we have a whole lot of patients and a lot of poverty and a lot of uninsured, there's consequences. And the consequences is directly less face-to-face time. And if you don't have a lot of face-to-face time, how can you have these discussions? So again, there's no excuse for this not happening. There's one cartoon I like that is a doctor talking to a patient that says, I don't know how to tell you this, so I'm going to send you to somebody who does. And that would be palliative care. Or if I don't have the time to truly understand this, or I think it's going to be very complicated, I'm not going to not tell you, but I think this needs a bigger discussion. And there's a specialist who can help you and your family work through these issues and truly understand your options and come up with goals of care. Because without knowing what a person wants, how do I know how to treat them? What are some examples of goals of care? Cure tends to be the assumed goal of care. But better symptom control might be what's more important to the patient, rather than cure. Maximum quantity of life, make me live as long as possible, no matter the consequences. No matter what machines or how much pain and suffering you inflict, make me live as long as possible. I have patients who want this. Unfortunately, we tend to treat everybody that way. And that's not good. It's just not good. But I do have patients who want that, who want every possible thing I can do to make them live longer. And it's nice to know that, because it's not about closing doors. That's not, again, what palliative care, we're not here to tell you what you can't have. We're here to make sure that you get what you want after having full informed consent, if it's possible. Improvement of function, being cared for at home. If the cure to this disease means that I'll never be able to care for at home, that I'd have to live in a facility, maybe I don't want that cure. That's reasonable. Not many doctors will tell you that, though. Spending time with friends and family. If the most important thing is spending time with friends and family rather than living longer, you might not want to be in the hospital. We make it hard to spend time with friends and family, especially if you're in an ICU. And avoiding unwanted or potentially burdensome interventions. Well, I'd want everything except to be on a breathing machine, or I'd want everything else except to have a feeding tube. Well, you have to really talk about that in advance, because usually once you need one of those two things, you can't talk. But telling the truth is hard. One of the studies looked at doctors estimating life expectancy, or at least what they told patients. And when you actually looked into the future of what happened, the doctors were wrong by a factor of 5 in an overestimate. So if a doctor said a year, it was more like 2 months. Is that not telling the truth? It might just be being very optimistic. But trying to tell the truth about what to expect, what are the consequences, acknowledging that the doctor doesn't know everything. We can't predict the future. We don't have all the answers. But this is most likely what to expect. It's not easy to do, but it's necessary. And choosing language carefully to avoid unintended meanings. This idea of we're going to withdraw care, there's nothing left to do, stop aggressive care. Do you still want us to do everything? Everything is, in the language of palliative care, is like the F word. Because everything is very vague. What do you mean by everything? Everything possible? Because everything possible involves a whole lot of stuff that's not going to work. Just because I can do it doesn't mean I should do it, and definitely doesn't mean you want me to do it. But if you say do everything, and I have a machine, maybe I'm going to put you on it. That's a bad thing. And if a doctor comes out of a room and asks the patient's family, do you want me to do everything? 99% of the time the answer is yes. Because I didn't give you any alternatives, did I? And I didn't explain what everything is, and I didn't give you my opinion. And suddenly I laid all the medical decision making in the world on your shoulders. I almost wiped my hands of it and said, how would you like me to treat this? Almost like asking, the surgeon telling you, so where would you like me to make the incision, and what size scalpel should I use? We never do that. We're the experts, but suddenly we're asking you what to do. That's not a good sign. Better to say, we'll always provide care. And sometimes the burdens outweigh the benefits. And this treatment is unlikely to produce this outcome. And this is what we should do, or these are the options that I would recommend. And physicians don't need to make options of everything that's possible. Physicians should only offer things that could reasonably be assumed to help the patient. And we do this all the time too, but we don't do it often enough. A surgeon will come and say, I'm not going to take you to the operating room. I don't think you'll make it, so I'm not going to do it. But for a medical doctor to come and say, I'm not going to do CPR, which has been proven time and time again to actually not work for most patients, suddenly that's not allowed. It's pretty contradictory. So the best way to deal with this is actually plan for it ahead of time. Have this discussion about goals of care and empower patients to make their own decisions when they can about their future. And that's the power of the advance directive. The advance directive is, in the patient's own words, how they want to be treated in certain scenarios. And it's truly a gift that people can give to their loved ones about relieving them of that burden of uncertainty about how to proceed if some doctor comes and asks them, do you want me to do everything? To protect them from that. So a discussion of advanced directives is something else that I do routinely. In our patients, when I'm consulted, only 10% of our patients have an advanced directive when I meet them. 1 in 10. After, it's like 75%. Still not everybody. Not everybody chooses to do this. But most people would. But we're waiting till a time of crisis to do it. It helps to designate a surrogate. A surrogate is an important thing. Who's going to be the patient's voice if they lose their voice, one way or another? Who's going to speak for the patient? And that person, that designated surrogate, should understand how the patient would want to be treated in a certain situation, or in general, what's most important to the patient, what are their goals? Because you can't plan for every possible scenario. So that surrogate could listen to what the doctors say and then speak with the patient's voice, basically. This might be different than what I want, but this is what the patient would say. That's what the surrogate's role is. So picking that person and having a discussion with them about your wishes and your goals is really part of this advanced planning. Documenting healthcare preferences, encouraging a discussion with the family, because if a paper is just sitting in a drawer somewhere, it's no use. So making sure that everybody knows it exists, what it says, what the wishes are, what the intent is, that the doctors or the hospital has it on file is valuable and it's a necessary part of this. Having time to discuss it with your doctors, your family. This needs to be done before a crisis. But after a crisis hits, if we have a window of opportunity, we try to get it done. And the advanced directive is not equal to a or what's called a do not resuscitate order, or a DNR order, and I'll talk a little bit more about that. It's not the same thing. An advanced directive is the patient's wishes. A DNR is an order done by the doctor. And what most advanced directives would say is, if, in the opinion of my physician, I have less than 6 months to live, if this disease were to run its natural course, then I want this. And the doctor might say, well, based on your wishes, I think we should put a do not resuscitate order. And I think maybe we should focus more on comfort. It kind of empowers the doctor to know what you would want in this situation. But the do not resuscitate order is an order done by a doctor. And in Texas, outside the hospital,